like to introduce our first speaker, who's Elsa Raker, who works at PHR's Asylum program, providing support to a network of more than 1,700 clinicians who conduct pro bono forensic evaluations to support asylum seekers. She contributes to PHR's growing partnership with medical school clinics and assists with the Asylum program's forensic evaluation trainings for medical professionals. Prior to joining PHR, Elsa interned at the International Rescue Committee, providing services to refugee and asylee clients resettling in New York City, among other amazing work she has done for this community. So I'll let you take it away, Elsa.
Thank you, and thank you everyone for joining us today. I just wanted to provide you with a bit of context about why you've asked us, or about why we've asked you to join us on this call. So during the start of the COVID-19 pandemic, it became clear that a lot of our programmatic work, which usually revolves around providing pro bono forensic evaluations to asylum seekers, was kind of taking a different shape, and that there were a lot of urgent requests coming in from attorneys whose clients were in detention and needing to get out, because as we all know, detention, prison, jail is really the worst place, or one of the worst places to be during the pandemic. So these attorneys are, we're still taking requests, and the attorneys are typically looking for an expert to review their client's medical records and write an expert declaration that serves as evidence in the client's struggle to be released from a facility. And sometimes the requests that come in are singular, so meaning that the client is kind of on their own, they're not part of any bigger litigation, such as one request that we received recently for a person in Arizona with lupus. But sometimes they're part of a larger class action with hundreds of other plaintiffs, all of whom might fall into a category of being medically vulnerable. So sometimes we receive these requests and the attorney will send complete, beautiful medical records, but sometimes they're incomplete or old or illegible. And sometimes the attorney doesn't have any records at all, and they are simply looking for an expert to speak to conditions of confinement and the great danger during the pandemic. So we know that these declarations work, and they're, if they're done correctly, they're seen by judges as being a reliable and authoritative piece of evidence in support of a plaintiff's claim for release from a facility. In the beginning of this work, we received, actually quite recently in this work, we received a nice email from a legal partner who informed us that actually these expert declarations are so effective that they have been able to support hundreds of people in being released from detention. So that said, the work is very much ongoing. It's really step by step and case by case. So we're continuing to receive the requests from attorneys and kind of field the requests out to the Asylum Network to see who is able to assist with each request. Just on the lines of it being really a step-by-step process, then on March 24th, the ACLU of Maryland and other legal partners filed a case called Correas v. Bounds, which asked for the release of 2 people from immigration detention who were vulnerable or extra vulnerable to COVID-19 complications due to diabetes and hypertension. And then on May 8th, a judge granted a temporary restraining order for the plaintiffs due to their medical vulnerability, and they were released from detention. So I'm going to put the link to this case in the chat so that you all will have the ability to just read up about it and also to view Dr. Ranit Mashori's medical declaration that she submitted in support of the case. So we wanted to have you all join us in this work. It's really been ongoing, and I've now just over the weekend received 2 new requests from attorneys. So we're hoping that, given that we don't know how long this work is going to go on for, we don't know what will happen with the pandemic, and that really it seems that the movement to guarantee people released from detention and prison and jail is really kind of just incredibly important work right now. we're hoping to increase the capacity to do this. So we're hoping that after you confirm, after you see this presentation by our great panelists, that you will take an interest in the work. If you haven't done so already, perhaps roll it out at your clinic, and that we will be able to share your contact information with legal partners who can then reach out to you. The Asylum and Refugee Committee is going to be your first point of contact with these ongoing questions, as mentioned in the beginning. And we are definitely here to support you in this work. So feel free to also reach out to me at PHR, and I can put my email in the chat box as well. I will turn it back over to you.
Thank you so much, Elsa. So we're going to go into the agenda for today. So we're going to start with Introduction to Expert Declarations by Dr. Ranit Mashori. Dr. Mashori is professor at Georgetown University School of Medicine, practices a full spectrum of family medicine, including obstetrics. She has a master's degree in international health from Johns Hopkins University. She's been working tirelessly for human rights, migrant health, and mitigating health disparities. She's been a member of the Asylum Network since 2006 and has served as an expert consultant to the PHR Program on Sexual Violence and Conflict Zones since 2011. Dr. Mashori has also served as an advisor for the Georgetown University Asylum Program since 2014 and has been an inspiring mentor for all of us in many projects around the school. Thank you, Dr. Mashori.
Thank you so much. I'm going to share my screen, so bear with me for a moment. Okay. Can you see it? Thumbs up? Yes? Okay. All right. So what I want to do is just review very briefly what needs to be in an expert declaration, and then some best practices. And the idea behind a declaration is you need to convince somebody, you need to convince the judge in this case, why a person or people need to be released. And you're doing this by convincing them that the disease is terrible, that the virus itself can be very problematic, leading to a potentially horrible disease, that the facilities can or cannot deal with an outbreak if it happens, and then specifically about the individuals that you may be writing on their behalf. So these are some of the issues. Again, we'll give you the access to these to the slides later, but these are some of the issues that you want to touch on when you write the declaration, and I'll go into each one a little bit more depth. So the virus, you need to describe what it is, and this could be a whole section in the declaration. So each one of these is a section in the declaration that you will be writing. For example, you'll describe what it is and how it's a novel virus. You want to talk about the R0, which is the ability of the virus to reproduce. So for example, we know that for the novel coronavirus, it's between 2 and 3 in the community, but in some correctional settings, it could be as high as 5 to 10. What is the infectivity of the virus? And usually it's a good idea to compare it to something that people are more familiar with, like the flu vaccine. So you would say, you know, this is 10 times more infectious than the flu, for example. You want to talk about how it is transmitted. I don't know why I didn't include that here, but you know, droplets, and why that is important, especially in the context of congregate settings and enclosed settings, and how also it can survive on surfaces. Again, there are a lot of studies that document all of these, so these are just bullets that you need to think about. And then its lethality also in comparison with other infectious diseases like the flu. So that's a section of the declaration. Another section is about the disease itself. So of course the virus is not the disease, because it can cause, in about 80% of people, it doesn't cause severe disease. So you want to talk about what happens for people who do contract COVID-19, which is a disease caused by the virus. So how many of the people who contracted died? And these are constantly changing and shifting numbers. So if you wrote a declaration 2 months ago, the data that you're going to include today are completely different, because things literally change on a daily basis. How many are asymptomatic? How many will require some sort of medical assistance or medical care? How many will have to go into isolation? How many will generally potentially have to go to an ICU and more intensive care? So all of these issues need to be under the disease description that you're including. What are the symptoms? I'm including the picture of the of what's called a COVID toe, because this is a relatively new symptom. And again, this is also evolving. The symptoms that are consistent with or descriptive of COVID-19 are changing. So again, make sure that if you're writing something and you're submitting it 2 weeks later, you are going back and checking all the websites, you know, for the CDC and other medical organizations to make sure that you're not missing anything. How does the disease progress and what kind of treatment is there? And the reality is that there is no treatment, which is what makes this condition very, very problematic. So you have the virus, you have the disease. You want to talk about how it's a multi-system disease. And this is important because in a lot of settings, and we found that through some litigation, that ICE considers this still a lung disease, and the screening that they do only talk about fever, cough, and shortness of breath. And we now know that this is a multi-system disease. So you want to make sure that the judges understand that it's not just about the lungs, but it could be affecting every and any system in the body, that it might make people who have other underlying medical conditions more susceptible to severe disease. The recovery is very complicated, and we're finding more and more about how complicated it is, in fact, even for people with mild disease. So there are, again, new studies about prolonged recovery, how and why supportive care is the only thing available, how that we have no medication. So again, you're trying to convince the judge that this is a really bad disease and you don't want anybody in your congregate setting to be affected by it. We talked about people, sometimes the litigation is about people in specific high-risk groups. And again, those are changing also on almost on a week-by-week cases. This is just a general list of some of the high-risk groups. Recently, severe obesity was included. So if you have any individuals that have any of these or comorbidities from this list, it's important to not only document it, but also specifically talk about what those disorders are and how that confers either a high risk of contracting the disease or a high risk of having complications once you're infected with a novel coronavirus. So these are two separate things, right? It's the virus can be more easily contracted by certain people, and then certain people can have more worse outcomes because of their because they're in high risk groups. They're important to remember those things. So this also goes into a separate section of the of your declaration. When you talk about immigration detention, of course, these are not just adults, and so we need to think about children. There's evidence, of course, of this new inflammatory condition that needs to be mentioned. Early on in the epidemic, we wrote a few litigations related to children in OR facilities, and at the time, everybody thought that, oh, children are just, you know, maybe they're not even getting it or they're asymptomatic, and now we know that kids can get really, really sick. And so that's important to include. How does it affect women? You know, there's some new studies about impact on pregnancy and vertical transmission to the fetus. Again, need to remember that. And then also a very unique population that we have addressed in some litigation is hunger strikers, and how being a hunger striker and being malnourished may be a risk factor that enhances not only your ability to, your susceptibility to the virus, but your ability to fight it when you get it. So again, remember that each one of these will have to have its own section. We're seeing now that some of the ICE responses to us include, oh, what we're doing screening and we're doing testing. So I think it's important to include a section on screening and issues with screening, of which there are a lot, and also with testing. Just very briefly, right now ICE does screening for fever, cough, and shortness of breath. And as we know, these are no longer the main symptoms of this multi-system disease, and also many people present without a fever, without a cough, and with other symptoms. So again, it's really important to think about what they're doing and convince the judge that this is absolutely subpar it doesn't address the situation. Likewise with testing, how many people are tested, what are they testing for? So again, include sections about testing and about screening separately. Of course, with this condition, with COVID and with this virus, prevention is the key. So this will be the key, the core of your declaration about the need for physical distancing and why it's almost impossible to do it in congregate settings. Hygiene methods, so what happens in those facilities? Do they have access to products? Are they asking everybody to use masks? And of course, the idea that there is no vaccine, which is why we need to be super duper careful about anyone getting it, and especially people in high risk groups. So that's, again, its own section of the declaration. The settings are very, very important, and you may not have been, most people who write these declarations have never visited the specific facilities, but the lawyers are supposed to be giving you some information about the facility, and oftentimes if you just Google the facility, you'll find a lot of information. Some of the declarations are about jails, prisons, family detention, OR, immigration detention. There are many different ones. And for each setting, what you write in the declaration will be a little bit different. Of course, you want to write about overcrowding, how people and where people are sleeping, what is the size, the interior design, are people sleeping in or cohabitating or sleeping in dorm rooms, and how that might affect the potential spread of the virus. What are the medical resources and facilities available in the setting? So you want to create a situation where a judge who's reading it is saying, well, yeah, that sounds like a really terrible setting, and one that might facilitate the spread of a disease, and certainly maybe not even have the capability to address and take care of people if an outbreak happens in that facility. So all of these issues are really important. What are resources in the community? A lot of these facilities are in rural areas. So you want to say, well, even the rural area, there's maybe not even a hospital that may be able to take people when they need to be transferred for ICU care, and what the impact might be in that specific facility on the local community. The populations are in and of themselves very important. Each one of these populations has its own risk factors, but you also want to make sure that the judge recognizes that it's not just about the inmates or the people held in there, but also the guards and the vendors who go in and out are susceptible to the virus if the right measures are not taken. For example, in the prison population, of course, the people in general, the population has higher rates of chronic medical conditions. There's allostatic load. I'm not going to go into it, but you need to describe the population and why they might or might not be at a higher risk. So these are all the sections of the declaration. You start with a description of the physician who's writing it. And I'm saying physician is because even though you're medical students and maybe there's some residents and you can help writing it, the declaration has to come from a licensed physician, and that is for reasons of credibility in the eyes of a judge. So when a physician or a clinician is recruited to do this, they need to be able to state their opinion with a reasonable medical certainty. They don't have to answer every question that the lawyer has, but they need to make sure that they are giving opinion within their scope of expertise and not outside of it, because there is a chance that they will be called to testify. So you don't want to create a situation where, people write about all kinds of issues that the physician may or may not be an expert in. Of course, most of us doing this work have very, very strong political and opinions, but those do not belong in the declaration. So also in your communication with the team, anything can be subpoenaed, including emails. So please, no emails related to how awful the system is, and just keep that to yourself. And be professional as you're supposed to be in general. When you're writing the declaration, remember this is for the judge who's not a medical provider, and so avoid any medical jargon. But if you have to include it, explain what it is. So every time I write "are not," I explain what that is, or any other medical word that needs to be in there. Sometimes some private practices work alongside with public interest legal groups like the ACLU and others. They're very rich, and every once in a while they'll offer to pay the physician. It's okay usually we say don't take more than $1,000. I have not taken any money from them, but people can take the money and can donate it, or you can say I'm just doing it pro bono. But it's okay for some people to take money. It's not frowned upon. It's not going to create any issues with your credibility. If there are any conflicts of interest, declare them up front, or maybe not even take the case. And recognize it's very important that you may be called to testify. These days, it could be phone testimony or Zoom testimony, but if you're not willing to do that, don't write the declaration. I know we're kind of rushing through this, but we've had some issues of people copying and pasting, which means that some declarations have had to be withdrawn because they are identical from two people who seemingly don't know each other. So always provide your own work. We're happy to give you, I think Elsa's going to give you a template and an example. Do not copy and paste, write your own in your own words, use citations. You can always say, as in the declaration by Dr. So-and-so, I agree with that statement. That's fine. And then you can quote, but do not just copy and paste. And of course, the most important thing is Elsa can attest. Usually we get a request and they want it in 24 to 48 hours, which is insane, but that's the timeline of these types of emergency declarations. So if you don't think you can do it, don't wait for 48 hours and then say, oh, well, I actually can't do it because my kid has a birthday party, because by then many hours will have been lost. So again, please assess the clinician's ability to provide this within the time that the attorneys recommend. Always, Elsa also talked about the medical records. Sometimes there are medical records, sometimes they're better than others, sometimes there are no medical records. So, but what you can say is, you can, whatever you have. So for example, if you've never visited Adelanto, but you have reports from other organizations about conditions, you can say, as per the report by so-and-so, my understanding is that Adelanto is, has, 50 beds to a room or whatever, something like that. Sometimes if there are no medical records, they will provide you with affidavits from the people who are detained themselves about their medical status. And you can say, although I have not examined Mr. So-and-so and I don't have medical records to verify that he has diabetes and hypertension, by report, this is his clinical status, and based on this, I can say that blah, 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 blah. So again, you can still make an educated comment, and you won't be found liable if the information is wrong, because you're basing it on other sources of information, and you're saying what these sources are. This is it, very briefly. I think I was given a few minutes, so I'm happy to answer questions later on, and we're obviously happy to share the slides and other materials that we have at any time.
Thank you so much, Dr. Mashori. That was a wonderful presentation. I'd now like to introduce our next speaker, Jeremy Chang. Jeremy is a rising third-year MD PhD student at Weill Cornell, who currently serves as Director of Scheduling for the WCCHR. Thanks to his incredible leadership, the WCCHR scheduling team has coordinated 13 remote evaluations, with 10 more in the works, and over 20 expert declarations since March. So we're so lucky to have him speaking with us today. So without any further ado, I'll pass it along to Jeremy to talk more about expert declarations.
Okay, thank you, Pooja, for that generous introduction. Right now, I'm just gonna share my screen. Okay, hi everyone. And so as Pooja said, today I'm gonna be talking about WCCHR's experience with the COVID-19 expert declarations. And so there are a few things that PHR wanted me to specifically address. And these were, one, how did we get into this in the first place? Second, what infrastructure did we build in collaboration with PHR? And third, what are the current questions and challenges? And so to give some context, on March 14th, we received notice from the Dean of the Medical School that clinical clerkships were being suspended, and that for WCCHR's work, that medical students would no longer be allowed to be present at in-person evaluations. And so this was a time of uncertainty, as it was for a lot of people. On March 27th, we received an email from an attorney from the American Friends Service Committee, the AFSC. And in this email, they asked whether there are any doctors in our network who would be able to look at a detained client's medical records and identify any major risk factors that made them at heightened risk for COVID-19 or for complications of COVID-19. And that if the clinician were to find anything, the attorney was hoping that the clinician would write a letter to the ICE officer describing why the underlying conditions make them vulnerable for COVID-19 or its complications, and that this letter would then be submitted as part of a formal ICE release request. And so at this point, we were at a crossroads already, because usually when we have cases that have requests that are atypical, and this would be considered an atypical request, normally what WCCHR does is that we simply reach out to our evaluator network and then connect the attorney with the interested evaluator. And that would be the extent of our involvement. We would never see the finished product or hear what was the outcome. But however, the other option was that we could choose to become more involved beyond that. And so for Tara, Pooja, and I, we got excited because this seemed to be a new opportunity that we could get involved in. And with our regular programming with asylum evaluations being in flux, we thought that this could be a good opportunity to grab onto. And we also suspected that with these cases that there is larger demand beyond just this individual case. And so the next day on March 28th, we sent a response to the attorney, and we included these 3 questions that we had for the attorney, which really reflected our main concerns about getting more involved in this work. First was simply what was the rationale for the attorney believing that the client had an increased risk for COVID or its complications. Second, what format were the health records in? Because if the health records were inside an electronic medical record, an EMR, then the project would be dead in the water, because I think that it would be almost logistically impossible for an outside evaluator and medical student to get access to these records. And luckily that wasn't a problem. Almost every attorney that we've worked with has already had the PDF files on hand and ready to send. And the third was, has the attorney already received consent from the client for an evaluator and medical student to look over their records? And so these 3 questions would become our initial 3-question intake, in which if attorneys wanted to send any cases to us, they would email us and answer these 3 questions. And so that same day, we reached out to our evaluator and medical student networks for volunteers, and we were able to get a really good response, especially from medical students. There was a lot of excitement about doing this type of work. And this email on the right, this is the connecting email in which we connected the attorney, the medical student, and the evaluator all together. And this would become our initial email template for assigning cases. And on March 30th, by that time, the evaluator and medical student, they had reviewed the medical records. And at this point, the attorney recommended to us that the format could be a simple 1-page document, and that this one document could have only a few paragraphs. And so on the right here is the letter itself. And as you can see, it's very short. It simply says, this client has type 2 diabetes, is on insulin, hypertension, male gender, above the age of 50. And so a couple days later, we were able to learn from the attorney that ICE had accepted the petition and that the client had been released from the detention center. And so for this very first case, we were successful. And already by March 30th, we were working on multiple cases. But at least for this case, things went perfectly fine to lull us into a false sense of security. And so, that first case was successful, but then as we took on more cases, we experienced growing pains and we started to experience more problems. And so for us, with these problems, we were trying to parse whether these problems were simply inherent in the process or whether they were things that we could make actionable items for to solve. And so looking back on it, I think that a lot of the problems that we experienced as a clinic stemmed from one root cause, and that root cause was that a number of the cases that we were working with, the client did not have any recognized risk factor for COVID-19, such as hypertension, diabetes, asthma, or COPD. And so this contributed to a number of problems. First, which pained me, was that a lot of evaluators and medical students seem to be having a poor experience with this, because I think there was a lot of confusion on what to do when the assessment was that the client did not have any strong risk factors for COVID-19. And when evaluators would email attorneys back and say and respond that there aren't that many risk factors, that there are no risk factors for this client, there would be a lot of back and forth between the attorney and the evaluator, in which the evaluator, they're operating in good faith in the sense that to do their job, they need to look at every possible detail and to try to argue it to support their position. And so they would email evaluators, asking about certain lines in the medical record and whether that changed their medical assessment. But overall, in the email chains that I was involved with, it was never very productive, and it never really changed the evaluator's impression. And so that wasn't very helpful. And of course, this is still, I think, for our clinic, an open debate on whether writing general letters in which the main crux of the argument is focuses on congregate conditions, whether that does make an impact for the ICE petitions or in the courts. And also at this time, evaluators and students were making calls for us to screen cases before assigning to evaluators and students. And finally, there is a separate point about concern among evaluators about potential post-release plans. And so there was a case in which the evaluator had asked the attorney, "Oh, what's the post-release plan for this client?" And the attorney responded, the attorney responded that the client is homeless. And so that sparked a question for us and for that particular evaluator about whether what we were doing was actually beneficial for the client, advocating for their release, and that maybe they were better off in the detention center than living homeless on the streets. And so at this time, we were working independently of PHR, and then PHR reached out to us, and they said that they had heard that our clinic name was floating around in the Asylum Network email listservs because we were offering this new service. And so PHR and WCCHR, we started exchanging information. And at least on our end, it was really helpful because we got to understand how our project fit into this larger ecosystem and realm of the COVID-19 expert declarations. And so we started talking about our problems, and we created a list of actionable items we could do to help solve the problems that we were experiencing. And so this was in partnership with PHR, and this was rolled out around April 18th. And so the first thing that I'll talk about is the intake form. And so we transitioned from the 3-question intake form to this more comprehensive Qualtrics form. And the benefits of implementing the intake form was that we were able to automate the process of receiving the case requests. The information was better organized. We were able to ask for more information. And with this increased information, we were able to potentially screen cases if we had to. And of course, with this intake form, we were able to ask about their post-release plans. And so just very quickly, I'm gonna go through the intake form right here. And so with the intake form, this is the first page is just a list of policies that we have. It's nothing, it's all very harmless. And so the attorney clicks that, yes, I wish to proceed. And now this page, we request simply the attorney information. It's modeled after the PHR intake form. And then we ask for the client information, their name, country of origin, alien registration number, and what detention center they're currently at. And then we ask about the particular case details. So the type of case, whether they want this for an ICE release request or a habeas petition or individual lawsuit, they're allowed to click all 3. And what we've seen is that attorneys often use the letters for multiple avenues. Usually the pipeline that we've seen is that the attorney first petitions ICE with our declaration, and if that fails, then they move on to other avenues, such as the habeas petition or the individual lawsuit in courts. Target declaration date, and as Dr. Mashori mentioned, it's usually in the realm of less than a week. And then, you know, has the attorney received consent from the client? What type of documentation? Are they ready to send the documentation? Is the client, are they working with the client on a pro bono basis? And then here we have we request a case description. And so I find this kind of funny because we kind of make the attorney write at the beginning of an HPI, but essentially we want it in the format of, you know, the client is a blank-year-old man who's currently here with a history of these conditions that are hopefully relevant to COVID-19. And then after a preliminary read-through through the client's documents, are you able to find evidence of the client's claims? So if the client, or if the attorney clicks yes, then on the next page it asks, okay, you know, this could be helpful if you could from your read-through, if you can specify certain pages that can help the evaluator and the medical student reassess those. And then finally, in the last question, we ask, what is the client's post-release plan? And so if the client is homeless, what arrangements will be made if the client is released? And so this is just to ensure some accountability and to force the attorneys to have some type of plan, at least outlined for the client if the outcome is successful with the declaration. And so with the email template, this is a new email template that we rolled out. It's in which it was helpful or beneficial because it helped clarify the roles of all the parties. We included more reinforcing language that evaluators are not obligated to write a declaration if they don't think one is justified. And with this new email template, we attached our new declaration template as guidance. And so the email template here, the top part is relatively similar to the email template that we used originally before in the first part of the presentation. But however, we added this section below in which it talks about formatting the declaration and also has individual sections for each of the parties and what their defined roles are. And so, you know, the attorney is responsible for providing the information and answering questions and updating outcomes. And here, this is the section for the evaluator. And then finally, for WCCHR, we always try to include medical students. And so in this case, the medical student also has duties, and they generally write the first draft of the declaration and then send it to the evaluator. And then finally, we had this new declaration template in which this is a modified version of the PHR declaration template that was sent after their seminar. And so there are a lot of benefits with this new template. One, there's more structured guidance for writing a declaration for the evaluator and the medical student. It included more comprehensive information and incorporated discussion of congregate conditions. So in our template, you know, based off of the PHR template, section 2 talks about the disease and the epidemiology. The third section talks about the congregate conditions of prisons and jails. And then the fourth talks about the individual case of the client and their health conditions. And so when we transitioned from the one-page format to this more comprehensive format, we asked an attorney which one they liked better. And they said that for ICE petitions, it didn't matter whether it was the one page or this more comprehensive version. But for the habeas petitions and the lawsuits, which are seen in the courts, the attorneys preferred this new declaration template more because it was more versatile and they could pull more information from the document as opposed to the one-page format. And so overall, for all of our declarations, we essentially require the evaluator to write in this more comprehensive format because it seems that, you know, if the ICE petition fails, then the attorney can still use it for the habeas petitions or for the lawsuits. And so for our numbers and outcomes, we've assigned a total of 22 cases for evaluators to review. 20 of those cases have been affiliated with the AFSC, and the others have been the ACLU and the Bronx Defenders. we've engaged about 9 unique evaluators and 17 medical students. Of the 22 cases, 16 letters or declarations have been written, 9 of them in the one-page format, 7 of them in the new declaration template. And so far, we've heard back on 4 positive case outcomes. Two of them were court mandated, and one of those 2, the initial ICE petition was rejected by the ICE officer, but then the habeas petition was accepted in court. And we've had one case, the first case, in which the ICE petition itself was successful. And then finally, we had another case in which ICE granted a low bond, and from that, the client was able to be released from the detention center. So now I'm going to be talking about the lessons learned, and there are probably 3 points that have been reinforced throughout our experience. The first was that both ICE and the court system right now really rely on the CDC risk factors when evaluating the merit of a case. And so WCCHR, we have been able to read one of our positive case outcomes, the actual court decision, and it seemed that they really relied on the CDC risk factors. And so that leads to the branching point of, the most successful declarations are those in which the client has at least one risk factor for COVID-19 as recognized by the CDC. And so of all of our 4 positive case outcomes, all of them have had at least one risk factor, whether that was asthma, diabetes, or obesity. And another learning point was that if the supply of evaluators is limited and you're being inundated with a lot of cases, then screening cases is probably necessary. And then finally, this more formalized declaration format, it makes the document more helpful and more versatile for attorneys. And so for our current questions, this is still based off of our previous slide in which, our open question is, do our declarations help in cases in which the client did not have any risk factors for COVID-19 or as recognized by the CDC? Do declarations in which the main argument is based on the congregate conditions, does that actually impact the decision whatsoever? And so that leads us to the more thornier question of, should we only take on cases in which the client has at least one CDC risk factor? And the second question that we had is, what is the timeline in which we hear back on outcomes for these declarations? For positive outcomes, it's more clearly defined, but for negative outcomes, it's harder because, as I mentioned earlier, the attorneys, if one method doesn't work, then they usually try to go through multiple avenues. And so hearing back on a truly negative case is more difficult. But I think the plan is that in the coming weeks or so, we'll reach out to the attorneys and ask for outcomes again. And then the last question is, a question that's on all of our minds is, what is the future of this initiative? I'm glad to hear that PHR, is still receiving cases, at least on WCCHR's end. Not many cases have come in the past 2 weeks. So maybe in the New York area, the glut of cases has ended, but maybe in other parts of the country, there are still many cases to be worked on. And so I just wanted to thank Elsa, Hajar, and Catherine and from PHR for their support, and all of my WCCHR friends. And that's the conclusion of my presentation.
Thank you so much, Jeremy, for sharing your thoughts. That was really helpful. So now I just wanted to quickly talk about next steps for asylum clinics who are interested in participating in this endeavor. So I think to Jeremy's point of the WCCHR's difficulty in writing letters for non-CDC risk factors, a lot of that has to do with clinician bandwidth and medical student bandwidth in conducting lit reviews under such short time frames. So to help combat this, the committee has decided to create a shared folder, not only with expert declaration templates and the presentation materials shown here today, but also with some comprehensive literature reviews conducted by asylum clinics across the country, so that people might share references and, again, not copy and paste, but use use those references in support of perhaps medical conditions that aren't recognized by the CDC. So that's one big takeaway. Something else, so in terms of how this will work then, PHR will be sharing your clinic's information with attorneys, so you can be expected to be contacted directly by by attorneys. We don't know how many referrals you'll get, but of course, if you're at capacity, then you are more than welcome to decline, and then the attorneys will reach out to another clinic. Luckily, we have enough clinics interested in participating that we hope that attorneys will be able to find someone to assist with them. Just remember that because the turnaround for these cases are so tight, that it's important to say upfront as soon as possible if you're not able to accept the case. And finally, I posted our email in the chat, but if you have any initial questions, please reach out to the committee, either to your individual representative or through our main Gmail account. And if we're unable to answer your question, then we'll loop in the appropriate individual to help answer your question. So with that, I'd like to turn it over for a more general Q&A session. I don't know if any questions have rolled in through the chat, Melissa and Katrine, but if not, anyone on the call is welcome to unmute themselves and ask questions at this time of any of our speakers.
So I had a quick question, actually. I'll start my video. So I'm at MASC, and we're a newer clinic with only like 3 or 4 PHR evaluators. And I guess like the concern we had was like kind of being like getting the short turnaround time with like such few physicians, so we don't want to like burn them out. And so I guess like the screening idea was interesting to me, and so I was curious to what like parameters would you suggest screening like potential cases with?
Jeremy, do you want to take that?
Yeah, sure. So yeah, that's a great question. For the screening, with the intake form, we're able to get a pretty good idea of what angle what information the attorney is working off of. And for us, it is that, whether there are any CDC risk factors. I think that's the main screening factor that we've used. I mean, I think at this point, for us, we try to be as inclusive as possible and to try to help as many cases as we can. I think at this point, we've only declined 1 or 2 cases, and one of those cases we were able to refer back to PHR to help with. But I would say in terms of like looking at the merit of the case in the eyes of like an ICE officer or a judge, the CDC risk factor is like the main thing.
Thank you.
Jeremy, we have another question for you in the chat. What is the ideal number of med students per declaration, and have you all tried putting more than 1 per case?
Yeah. So that's a great question as well. I would say for this that 1 student is more than enough per case. And that I think if you have multiple medical students, it would be too many cooks in the kitchen. And even there are some evaluators who are so incredibly efficient with this process that they can get everything done in a day. And there's been one case in which an evaluator has actually just done everything and just like didn't give any warning to the medical student. And so in the end, the medical student didn't actually contribute anything. And so, yeah, I would try to keep it to at most 1 medical student per case.
This is Dr. Mashori. I just wanted to add one thing, is that in a number of cases that didn't go as expected the first round, there was a second round where where we were called on to provide a second declaration in response to what ICE and other authorities have said about the initial declaration. So I know that I didn't include that in my slides, but that's something to let evaluators know that they may have to do a second round of responses, and that could be a role for medical students again.
That's really helpful to know. Thanks, Dr. Mashori. Another question in the chat, maybe for Elsa. Does PHR have a list of resources that evaluators can use to put together the sections on virus, disease, and descriptions of the detention facilities? I know we have some templates for clinics to access, but just for completeness sake.
Yeah, I think that this would be addressed in the shared folder as well. I think this is also something that we really want to put together with all of you. So as you're working on these cases, then if you can send your resources to the committee, then, or just add them to the shared folder, then that would be great. At the moment, PHR doesn't have a list of resources specifically on the virus, disease, and descriptions of the detention facilities, but certainly I'm sure there will be kind of ample information about that as you start to assemble the folder. And additionally, you can always rely a bit on the attorney to read more about the facility. They might have, they're the ones working on these cases, and so they might have very good resources for you to look at. And they also will frequently send a declaration that another clinician has already written for the case. Sometimes they're looking for more than one expert per case.
And I just wanted to add, this is Dr. Mashori, a disclaimer here that even if you have resources about the virus and the disease and all of that to be very mindful, as I said before, that everything changes so rapidly. So do not rely on stuff from April or even May or even early June, because you will have to re-look at the literature and make sure that there no new data has come.
All right, are there any other questions for the group?
This is also, again, I just wanted to add one more point about tracking case outcomes, which and also just to commend the WCCHR's efforts in putting together this amazing infrastructure for taking these requests. I will be very frank that PHR does not have the same infrastructure. So really we've been screening cases sort of case by case and haven't rolled out an intake form or anything like that. So it might also be a good idea to see sort of what demand you find, and then sort of think about how to build out an infrastructure that accommodates what requests you're facing. And then just on the note of outcomes as well, as Jeremy mentioned, it's often the attorney is very excited to tell you when a plaintiff in a particular case has been released. But we've also found that these litigators are really working around the clock on so many different cases, and so it might take some follow-up to just ask for the outcome of the case. And then usually in the screening process, I will just add a question of, is this case related to a bigger class action? And this is on the WCCHR intake form as well. But if they say that it is part of a bigger class action, to ask what the name of the case is. So for instance, in Correas v. Bounds, which is now in the group chat, you can very easily look up the outcome of the case online.
Thank you, Elsa. Any last questions? We have 2 more minutes, I think.
I have a quick question with regards to an intake form. So our clinic at NYMC, it's relatively small, though we have maybe 8 to 9 evaluators interested in assisting with the expert declarations. We haven't yet rolled out an intake form for such cases. Do you suggest that we do something like that, or do we wait on PHR to kind of filter the cases and send them out to us?
I guess so. To answer your question, so the attorneys will be reaching out directly to your clinic. So in that sense, PHR won't be modulating the flow of expert declarations like they might for your asylum evaluations. So sort of to reiterate what Elsa said, Jeremy and the scheduling team developed the intake form in response to the fact that the WCCHR couldn't accept all the cases that we're rolling in, it might be beneficial to wait a little bit to see what kind of cases you're getting, and then at that point establish an intake form if it's necessary for your team.
Okay, thank you so much. Sorry, I think I misunderstood earlier on, but thank you.
Sure.
That definitely to help.
Okay, great. And just for everyone, we'll be sending up a follow-up email sort of outlining everything that was discussed today, to sort of assess, to make sure that your clinics are on board with starting to receive these requests. We'll disseminate a share folder. Basically, we'll get you all the information that we promised in this webinar, so as well as the recording if other clinic members couldn't attend. So stay tuned for that. I think we're at the end of our time, so would just really, really appreciate everyone hopping on this call today. It was so lovely to see this many clinics express interest in this process. Like everyone sort of alluded to, it's unclear whether how long this will last for, but there does still seem to be a demand for these expert declarations, so your assistance will be invaluable. So with that, I think we'll end here, but stay tuned for a follow-up email from the team. All right.
Thank you.
Thank you, everyone.
Thank you.
Everyone.
Thank you.
Thank you.
Thanks, Jeremy. It was great.